From Microbe TV, this is Infectious Disease Puscast, episode 73, recorded on Thursday, January 30th, 2025. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. So I will start by saying Happy New Year, Happy Chinese New Year, Lunar New Year to folks, but it'll still be kind of in the celebration window when this comes out, but it's one of my favorite holidays.
Are we supposed to say like lunar, include everyone? Is it just the Chinese that get to celebrate?
I think it depends who you ask. I think the at the heart of it, it actually is Chinese New Year and it's based on a Chinese calendar. But some people use Lunar New Year, although technically they're all different calendars. Anyways, that's a separate conversation.
Okay.
But I have noticed that people have pivoted to Lunar New Year for a lot of things. Oh, I have a very fun lion dance hat that I was gonna wear and I forgot. I'll have to save it for next year.
Okay. I have a colleague we cover with. He's originally from Malaysia, and so he was off yesterday celebrating. I was not invited to the celebration, so just.
I know. I realized this year, I'm like, oh, I should take that day as one of my holidays. Next time, planning for the next one.
Okay.
Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we? And I will open us up with viral. Please remember to listen to This Week in Virology and Daniel's clinical updates. The first thing that I pulled was an update that was posted for Hep B guidance. So the AGA clinical practice guideline on the prevention and treatment of hepatitis B virus reactivation in at-risk individuals. That was published in Gastroenterology. As just a high-level overview, the guidelines recommend antiviral prophylaxis over monitoring alone for those who are high risk of Hep B reactivation, and they suggest for those at moderate risk. I think for most people, you probably are thinking about what's in Figure 2, which is how we want to check that serology and establish that baseline, and then think about low versus moderate versus high risk based on that Hep B surface antigen. And so I added this figure here. That's their primary clinical decision support tool. I thought, though, that Table 6 is another really nice reference because it has a summary of baseline risk based by drug or the agent, I guess I should say. And so just to pull out a piece of that, I'm just going to summarize and read off the high-risk drugs when we think about Hep B reactivation. Anthracycline derivatives, B-cell depleting agents, anti-TNF agents, tyrosine kinase inhibitors, cytokine integrin inhibitors, CAR T-cell therapy, anti-IL-6 agents, JAK inhibitors, those with Hep C co-infection undergoing treatment with direct-acting antiviral agents, TACE, transcatheter arterial chemoembolization, and those who are on moderate or higher dose steroids, which they define as 10 to 20 milligrams or over 20 milligram predose equivalent for at least 4 weeks. So I have one of these actually saved in I always take the image and save it in a folder in my Google Drive, which is my document storing website of choice. So folks can make sure they have the updated one in there.
No, I appreciate that you went through the list. That's helpful.
Yeah. I really, I feel like hopefully we are seeing, a lot of these patients or communicating with folks that put them on medication. I think most people are at least peripherally aware of the high-risk ones by having it sort of broken down in a very nice traffic sign, low, moderate, high-risk algorithm is always nice to have.
All right. Well, we have the article Host Microbe Multi-Omic Profiling Identifies Distinct COVID-19 Immune Dysregulation in Solid Organ Transplant Recipients, published in Nature Communications. This was sent in by one of our listeners, former mentee of mine. I guess always a mentee. I don't know. Now, and I understand the senior author, Chaz Langolier, is a TWIV fan, and I think also an ID Puscast fan. And he's also a fellow windsurfer. So, by the way, but this study looks at solid organ transplant recipients with acute SARS-CoV-2 and uses host microbe profiling to look for differences between the solid organ transplant recipients, matched controls. So a couple things, and the initial and not surprising, and then the other, I guess, when you think through, makes sense. So the solid organ transplant recipients have higher level of SARS-CoV-2. They say virus, but nucleic acid levels when they measure them, and impaired clearance when they're measuring that, impaired viral clearance. But probably the most interesting thing is they actually have, even though they're immune suppressed, you would say, hyper-inflammatory innate immune signaling at the transcriptional and protein level. And even though one would say, oh, well, that's the opposite of what you might expect with immunocompromise, if you think about the agents we're using, we're really targeting T cells, more of an adaptive. So maybe this all makes sense. And I think clinically, you're seeing less of an IL-6 based response. So sort of think about, the role or maybe the lack of a role of things like tocilizumab in this particular population.
And this one is also involving immunocompromised hosts. It's from CID. Refractory and resistant herpes simplex virus, I'm going to say HSV, mucocutaneous infections in immunocompromised patients, literature review, and proposed definitions for use in clinical trials. So this is not something we think about a ton with immunocompetent patients, but the reported resistance rates of HSV and those who are immunocompromised, the reports vary, but they range anywhere up to 14% in stem cell transplant recipients, probably somewhere up to 3% in solid organ transplant recipients, and 3 to 7% in the literature for those who have advanced HIV. And so this paper was from the HSV Resistance Working Group of the Transplant Associated Viral Infections Forum. I thought this was a really awesome review. They talk a little bit about mechanisms of antiviral resistance. As a high-level overview of that part, the primary mechanism for HSV 1 and 2 resistance are mutations in that viral thymidine kinase. And there's a really nice figure for that. They summarize risk factors, and you can see that actually split up by host viral and antiviral therapy factors in Table 1. And then they have some of those definitions for refractory infection and resistance outlined in the paper, and then they have a summary of that in Table 2. So I'm not going to dig too far into it, but I thought a really nice reference, and I encourage people to take a look.
All right. Well, so I've got this article. Insect-specific RNA viruses detection in field-caught Aedes aegypti mosquitoes from Argentina using NGS, so next-generation sequencing technology, published in PLOS, Neglected Tropical Disease. So here, these researchers employed Oxford nanopore technology sequencing platform to detect viruses in mosquitoes collected from various regions of Argentina. They tell us our findings revealed the presence of several viruses, including mosquito-specific viruses across different parts of the country. Just imagine this. Maybe we could make the mosquitoes sick and unleash viruses on those pests that keep giving us viruses. I'm picturing mosquitoes being wiped out by their own viral pandemic.
It's a good finale for our viral section. While I take us into bacterial, please be sure to listen to This Week in Microbiology. The first paper I thought was quite exciting. It's from the New England Journal of Medicine, Oral Regimens for Rifampin-Resistant Fluoroquinolone-Susceptible TB. So here we have the END TB trial evaluating newly approved drugs for multi-drug resistant tuberculosis. I think it's a good title. So phase 3 multinational open label randomized controlled non-inferiority trial. They compared standard therapy for treatment of fluoroquinolone susceptible rifampin resistant TB with 5 9-month oral regimens that included various combinations of bedaquiline, delamanid, I always stumble on that one, linezolid, levofloxacin or moxifloxacin, clofazimine, or pyrazinamide. Their primary endpoint was a favorable outcome at week 73, defined by 2 negative sputum culture results or favorable bacteriologic, clinical, and radiologic evolution. And their non-inferiority margin was 12%. So there were 699 patients included in the modified intention to treat analysis and 562 in the per protocol analysis. 80-ish% in the standard therapy group had favorable outcomes, but the risk difference between standard therapy and each of the four specific new regimens were found to be non-inferior in the modified intention to treat population. Those differences were similar in the per protocol analysis with the exception of one of the regimens. So in an effort to sort of summarize that, those regimens which produced that favorable outcomes in over 85% of participants were, this is all alphabet soup, BCLLFXZ, so bedaquiline, sorry, I should have written out so I'd be faster, clofazimine, linezolid, levofloxacin, pyrazinamide. There is BLMZ, but I'm scared I'll mess it up, bedaquiline, linezolid, moxifloxacin, and pyrazinamide, and BDLLFXC. So bedaquiline, delamanid, levofloxacin, linezolid, and pyrazinamide. Hopefully I didn't stumble on those.
No, you did that. Wow.
So the grade 3 or higher hepatotoxic events were more common in experimental groups, except for one of those. But overall, the take home is these are similar to the regimen. I think we talked about the TB practical paper that looked at the regimen of bedaquiline, pretomanid, linezolid, moxifloxacin, BPALM. And the WHO has endorsed the use of these 3 oral regimens over the longer all-oral regimens. That actually was back in the summer. And the nice thing is these regimens can be used in nearly all adults, children, and pregnant persons. And all the drugs have pediatric formulations and are recommended regardless of age. So pretty incredible and a very complex design. Like looking at that consort diagram, it is quite elaborate. So very cool.
All right. Well, I realize this is a topic where I probably have an axe to grind, but let's go ahead. The article, Impact of Antibiotic Treatment and Predictors for Subsequent Infections in Multidrug Resistant Pseudomonas aeruginosa Catheter-Associated Asymptomatic Bacteriuria, published in AJIC. So these are the results of a retrospective study involving hospitalized patients with multi-drug-resistant Pseudomonas aeruginosa catheter-associated asymptomatic bacteriuria. So the study cohort comprised 139 patients with multi-drug-resistant Pseudomonas catheter-associated asymptomatic bacteriuria. Subsequent symptomatic Pseudomonas aeruginosa infections were observed in 26.6% of the patients. And what did they find? They found that active antibiotic therapy for asymptomatic bacteria, which you're not supposed to do, was associated with a more than doubling of the risk for subsequent symptomatic infections, hazard ratio of 2.34. A beautiful Kaplan-Meier analysis demonstrated a significantly lower cumulative proportion of symptomatic infection-free patients among those that received active antibiotic therapy. So you really see this separation. It's really impressive. So I know there are people out there who may say, well, my patients or these patients that I get called about with asymptomatic bacteria, well, they require treatment. Well, I just want to point out that you are increasing potential harm. All right. The article, Identification of the Skip Phenomenon Among Patients with Staphylococcus lugdunensis Infective Endocarditis, a retrospective review, was published in Open Forum Infectious Disease. So I'm sure our listeners are familiar with the skip phenomenon from Staph aureus bacteremia, where you have blood cultures that are positive, positive, negative, positive again. So intermittently positive before final clearance. Well, that only happens if you keep drawing those blood cultures. So here, these investigators report that 1/3 of patients with Staphylococcus lugdunensis infective endocarditis experience this skip phenomenon. Patients with skip phenomenon experience both a longer duration of bacteremia and hospital stay. Well, okay, think about that, with a higher 1-year mortality rate. Now, I will point out, this is a small retrospective study, but now just like MSSA, MRSA, we are seeing this documented for Staph lugdunensis. Now, I'm not sure exactly what we do clinically. Do we keep getting extra blood cultures after we think they are cleared because there's a certain prognostic? Would it change management, right? Would you extend by a couple days your length of antibiotic treatment? So I will just put this out there.
And carrying on the endocarditis theme, I pulled this paper from OFID, Emergence of Infective Endocarditis Due to Serratia. I'm sure someone's going to be mad I'm not saying Serratia, but okay. Results of a multi-center cohort. This is a retrospective look at 159 adult cases of Serratia valvular endocarditis. So no device infections were included among 4 academic health systems in the window of 2015 to 2021. The authors reported these increasing rates, and I put actually the figure here. They have it demonstrated by all sites and then by the 4 that were included. Most cases, so 2/3, were among younger patients, so those 18 to 40 years old. 3/4 of the cases here were associated with IV drug use, and 70% involved native valves. The inpatient mortality was 21%, and about a third of those patients had, not of the mortality, had valve surgery. There are certainly, drawbacks being retrospective, and the sites really had different ways to identify cases at their institution. So it's hard to know if there are cases that are missing, but it is a large cohort out of what is published, I guess I could say. I think it's fascinating because we don't really know why Serratia would be more common. I think the author shared a couple theories, like what if susceptibility to endocarditis is related to the inoculum in the setting of direct injection into a bloodstream? Is there a more hardy, virulent biofilm bug that's really latching itself onto drug use equipment? We don't really know, but I don't know, it changes a ton. I think all of us probably raise a tiny, very small flag thinking about Serratia when you see it in blood cultures. But I thought it was at least a little bit of insight into some cases, and I'm blanking now on where those centers were, but they were spread out in a couple locations in the U.S.
Yeah, I'm kind of curious where they were. I'm just thinking about, have we ever talked about Operation Sea Spray, Sarah?
I don't think we talked about it on maybe we did. I don't know. I think you and I have talked about it, but I don't know if it's on the show.
Yeah, I mean, it's worth a mention, and maybe our listeners will want to Google. But as a biowarfare testing thing, first the U.S. military sprayed right over the San Francisco Bay Area, and then had the army on the ground, like with the petri dishes and the Serratia forming red spots. And so, we have Serratia in the water in San Francisco, and then they did a similar thing in the subways of New York City, where they had it in kind of like almost like a light bulb, and they smashed them in the air vents in the subways. And so we have Serratia. We see it here in New York.
I didn't know the New York part. It looks like it was North Carolina, Pennsylvania, West Virginia, and Kentucky.
Wow. So it's starting to spread all over the country. So, all right. Well, This is an interesting one. The article, Reduction of Vancomycin-Associated Acute Kidney Injury with Montelukast, singular, published in JAMA.
Singular.
In this retrospective cohort study, adult patients who received intravenous vancomycin with or without singular were compared. And so I'm not sure what's going on here, but apparently they've got patients, they're giving them singular, got an N of 110. They're compared to control, 330. AKI was observed in 2.7%, those folks getting singular, versus 10.6% in the people that didn't, p-value 0.01. So given folks Montelukast or singular, odds ratio 0.26%. Apparently male gender was also protective, 0.41 on the odds ratio. And they've got this in vitro model suggesting that the adjuvant montelukast can reduce injury to proximal tubule cells through activation of the P62 KEAP1-HO1 antioxidant pathway. So are we ready to start doing this as they suggest, or are further studies warranted to validate these findings prospectively? They want further studies. I'm sort of wondering if...
I wonder where this question came from. I mean, it just seems like an unusual drug for us to target at looking at combos with Vanc. I don't know.
You know, it is interesting because there is some of these ideas about using certain agents to prevent, you know, the oxidant pathways. So yeah, this is very clever. All right, I'm gonna cover the fungal section, and I am anxiously waiting. April, apparently, The Last of Us season 2 will be coming up, and I have 2 articles here in our fungal section. The article "Pulmonary Co-Infection of Pneumocystis jirovecii and Aspergillus species," published in Open Forum Infectious Disease, and I love every opportunity to remind people that Occam was not a doctor, and more than one thing can be going on. Here we read that in this multi-center study of 387 immunocompromised patients, 4.5% with invasive pulmonary aspergillosis also had pneumocystis jirovecii pneumonia. Predictors of co-infection included Sarah's favorite, an elevated Fungitel beta-D glucan. I know how useful that test is, and prolonged corticosteroid use. And this co-infection correlated with reduced 30-day survival. Actually, they went from 22% versus 57%, suggesting that early identification may improve outcomes. All right, in CID, we have the article, Impact of Fluconazole on Outcomes of Patients with Primary Pulmonary Coccidiomycosis, a commercial health insurance claims-based propensity score-matched analysis. So what's the story? Patients with pulmonary cocci often experience prolonged symptoms lasting weeks to months. Now, what do you want to do? You want to do something about that, but many providers may not realize that limited data exists regarding whether fluconazole prevents development of disseminated disease or even shortens symptom duration. So here they looked at immunocompetent patients aged 18 to 64 with pulmonary cocci. Among 1,448 patients with pulmonary cocci, 659, so about half, received fluconazole. Patients who received fluconazole more frequently had a pre-diagnosis symptoms, right? So 95% versus 72%, which makes sense because remember, this is a propensity score-matched analysis. And antibiotic prescriptions, interesting enough, 68% versus 32% than those who did not. Among the propensity score matched subset, hospitalization, we saw 4% versus 1%, disseminated cocci 3% versus 0%. So more frequent among patients who receive fluconazole. All the limitations of this type of study design, selection bias, who gets treated, right? Because you're going to treat people that you're a little more worried about. But ultimately, they're doing this matching, and this does support existing guidelines that fluconazole may not be associated with improved outcomes for immunocompetent patients with pulmonary cocci. So another keep your hands in your pockets. All right, and parasitic, be sure to listen to This Week in Parasitism. The article, Comparative Outcomes of Babesiosis in Immunocompromised and Non-Immunocompromised Hosts, a multi-center cohort study, was published in CID. And not surprising, as we read here, that in this multi-center retrospective cohort study that looked at 225 adult patients with lab-confirmed babesiosis, those with immunocompromising conditions had higher complication rates and more severe disease.
Love it.
All right, miscellaneous. That's all you, Sarah.
Miscellaneous, yes. So I thought there's a paper in the Lancet on hidradenitis suppurativa, and I had to just read off the starting sentence because people always talk about starting with the hook. People have a high awareness of their skin, which is a visible and palpable organ. I don't know. It pulled me in, I guess. So hidradenitis, folks know, we've talked about it a couple times, inflammatory condition that has these persistent or recurrent, really like deep-seated painful nodules, abscesses, and often tunneling in the skin, usually in the axillary or inguinal areas. So they give a lot of background, but I thought it was really interesting because they included even a section called Life Effects, actually focusing on the negative impact that HS has on the physical, mental, social, and professional domains for patients, which is really cool. I don't think many reviews really talk about that. But I was here for the treatment section because I wanted to see if that sneaky carbapenem recommendation that we often hear about or asked about snuck its way in. And I will quote, overall, there's limited evidence supporting systemic antibiotic regimens. So they mention combinations of oral rifampin and clindamycin or monotherapy with oral doxycycline, which has been studied previously, but no mention of that 6 weeks of carbapenem that I have been called about before. But the things that I learned a lot about is there's a lot of new biologics out there that can potentially be used for moderate or severe disease, like adalimumab, secukinumab, and a super new bimekizumab. So I was just going to say what's not to love. It's a very well done overview. I learned something and no one recommended a carbapenem. So
yeah, no, this is I was going to grab this one. I was reading through it, and then when I went to paste it, I'm like, there it is. And I mean, this is one of those diseases where, I mean, this is kind of why you go into infectious disease, where there are people who are suffering, and a lot of times I don't think that clinicians have the expertise in this area, and it's a very challenging and really life devastating situation. We have a really, I have to say, really good hidradenitis suppurativa clinic at Long Island Jewish, actually, in Queens here, that really is able to help these folks and, uses some of these newer biologics.
Yeah. Oh, and I have to give a shout that they do have a couple images, and they specifically incorporated pictures of different skin tones, which not all our textbooks and articles do that. So I thought that was cool.
Yeah, some of those pictures are quite graphic. Yeah, excellent article. So for our fun and interesting, we have the article, a severe case associated with mixed infections of Pasteurella multaceta, Bacteroides pyogenes, and Fusobacterium necrophorum due to a snow leopard bite, a case report. This is published in CMI, and here we read about a 33-year-old male admitted to a local hospital located in Jiaquan City, Gansu Province, China, with head injuries caused by a snow leopard bite 48 hours prior, accompanied by symptoms of headache, fever, palpitations. I pasted in a really cute picture of the snow leopard from the Bronx, the Central Park Zoo here in New York City. I would have loved, in this article, a little more details, like trying to figure out, like, why was the snow leopard biting this guy in the head? What was going on there? What was he doing with his head so close to a snow leopard?
Oh, my goodness. And I think I have our last paper. This one is from OFID. Inside Out, Introduction of Speakers at ID Week Events, Observing for Unconscious Bias Over Time. So this study looked at disparities in how speakers are introduced at ID Week. Their Inside Out study group team reviewed video recorded speaker introductions from the 2013 to 2019 archives. The intros were coded as professional if moderators used titles or some similar honorific like doctor or professor, and then were coded non-professional for those referring to speakers without those titles, using first name only, that type of thing. So of 1,940 speaker slots, 45% were introduced non-professionally during their first introduction. 42% were never introduced professionally the whole session. The rate of receiving a non-professional introduction did have an increasing trend year by year. It was closer to 50% in 2014, and then compare that to about 36% in 2019. Men were more likely to have a professional introduction than women, although it was not statistically significant. There was not a difference by speaker race or ethnicity. And lastly, I will point out that younger speakers more frequently had non-professional introductions, especially if there was a discordant moderator-speaker pair, sort of perpetuating that hierarchical structure, and can have a negative impact on those junior IDSA members who are really trying to share their expertise. So a really great paper and project, and they point to some key ways that we can improve, such as concrete things like incorporating these recommendations and data into ID Week moderator orientations. So awesome work. All right, and that's it, right? Yeah, that brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at www.microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com, and click on the donate button.
I'm Sara Dong. You can find me at Sara Windong or Febrile Podcast on Blue Sky, or at febrilepodcast.com.
I'm Daniel Griffin. I'm also on Blue Sky, but you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. End dictation, and goodbye.
Thanks for listening. Happy New Year. We'll be back in 2 weeks. Another Puscast is infectious.